I'll quickly review blood pressure and hypoperfusion issues. Hypotension appears well after hypoperfusion has been going on for a while, so if you wait until blood pressure drops, you've missed low perfusion for a while. There's three elements to perfusion: the pump, the fluid volume, and the vascular container. Then the pump can be broken down into its two parts, and essentially cardiac output is the pump function, and cardiac output is made up, as you know, between heart rate multiplied by stroke volume. So that gives us essentially four tools for improving perfusion if we look at the two parts of the pump and then the fluid volume in the container. We can increase the heart rate up to a point. After that point you don't get any further benefit because the faster your heart goes, the less time it has to fill, the less ventricular filling time there is, and the less time there is in diastole when that myocardium gets its blood supply. We can also increase stroke volume by increasing preload or by using inotropes. We can increase the fluid volume itself, either from IV fluids or actual blood, or we can try to decrease the container size by increasing vasoconstriction. So let's talk about each of the four things that we can manipulate in order to improve perfusion. Heart rate certainly is one of the first ones. As a major component of cardiac output. Heart rate between 50 and 150 are more normal ranges. Once you get above 150 or below 50, you certainly have a problem with maintaining cardiac output. Our chronotropes will help us increase the rate. The two chronotropes we have in our toolbox being epi and dopamine at this point. And then, in a way, atropine can be considered a chronotrope, although not technically, because atropine is going to block that parasympathetic tone and increase the heart rate that way. Transcutaneous pacing can certainly force the ventricular rate upwards in cases of high degree AV block, where atropine is not going to be effective, and other chronotropes can be used instead of or in addition to, in extreme cases, transcutaneous pacing. When you do transcutaneous pacing, you can certainly force that ventricular rate upwards and improve cardiac output that way. Diastole, when the heart is relaxed, not pumping, is when the myocardium has a chance to perfuse itself. And so myocardial perfusion is a key thing, and that's one of the issues with the heart rates above 150. There simply isn't enough time for that ventricle to get its blood supply. And also during diastole is when the ventricles reload, when the ventricles fill with blood to pump out. So heart rate impacts our cardiac output, and that helps us with perfusion. Another factor in perfusion that we can manipulate is stroke volume, to some extent. Inotropes, dopamine, epinephrine, inotropic agents will force the harder squeeze of the ventricle, improve stroke volume and therefore cardiac output. Beta-1 agents will give us that inotropic effect, so again, dopamine and epinephrine. We can also try to increase the preload because the heart can't pump out what it doesn't have. And so by increasing preload, we can improve stroke volume to a certain extent. If you remember the Frank Starling law and the rubber band analogy, where if you need a rubber band to pop harder, you need to pull it back more. And so essentially, if we can increase preload, then we can cause that ventricle to stretch a little bit, and so when it pumps, it's able to squeeze a little bit harder. If the ventricles are weak and damaged from MIs and other disease process, then that stroke volume is going to suffer, and there's probably a limitation to how much stroke volume we can actually get out of that weakened heart, and so we'll have some limitation on how much we can improve perfusion by increased stroke volume when the ventricle is damaged. And then also, if that ventricle is pushing against high pressure, if there's a high afterload, a lot of vasoconstriction in the arterial side, if the afterload is very high, those ventricles are going to struggle to force blood outwards. Perfusion can also be improved by increasing the circulating volume, again, up to a point. Our typical crystalloids, saline and LR, are only going to stay in that vascular space for a while. And there's some studies and some information from Dr. Jeff Guy in his pre-hospital pharmacology series that talks about how a liter of saline, a liter of crystalloid, after an hour there's only about 200 or 250 cc's remaining in the vascular space. So it's a temporary boost from those sorts of fluids. Now hypertonic saline, hypertonic fluids may stay a little longer, and blood, of course, will stay longer than that. But there is a limit to how much we can improve perfusion by adding volume. The preload increase can be achieved also quite simply, but temporarily, by laying the patient down. And we see this kind of in a negative effect in our CHF patients who end up calling us an hour or so after they have gone to bed. They've been up and around all day, and then when they lay down, they increase their preload to the point where their heart can't handle it. But we can use that to our advantage. That's one of the reasons for using the supine or nearly supine position in patients who have low perfusion as one of our shock treatments. And then finally, the fourth thing that we can manipulate in order to improve perfusion is the container size. We can use vasoconstrictors, alpha-1 agents, to cause vasoconstriction and reduce that container size down to where the pump's able to handle the available volume and the container size is not so large that the pressure will drop. Your body does this automatically in response to a lowered pressure. It causes an adrenaline release and peripheral vasoconstriction in an effort to shunt blood in order to reduce that container size and keep perfusion to the core, to the heart, lung, brain, and kidneys. Vasoconstrictors, the agents with alpha effects that we have in our toolbox, again, dopamine and epinephrine, they both have strong alpha effects. And then I want to mention vasopressin. Vasopressin, it doesn't work by the same mechanism as the dopamine and epinephrine, but does directly cause vasoconstriction. So, in summary, we can do things to manipulate the heart rate and the stroke volume, therefore increase cardiac output. We can do things to increase the volume, or we can do things to reduce the container size.